Okay, great. So yes, hi, I'm Eli Rosenberg, I sort of work at the intersection of some of the issues that Ben had laid out on the previous slide. So today I'm going to talk sort of about the intersection of disparities and social determinants of HIV infection among men of sex with men in the United States. And this is sort of an area where I've been working for a while. So I'm coming from Atlanta, Georgia, where this is really a very pronounced issue. Sort of continuing that work through some different stages of research here at the University of Albany. I'm going to jump into data. I'm an epidemiologist, so I'm going to blast you with some data. And I'm sorry, that's just sort of this is how I start a conversation. So HIV infection in the United States doesn't make as many headlines as it used to, but it's still a very prevalent epidemic. With over 1.1 million people in the United States are living with HIV infection. And we see persistently, depending how you measure it, about 35,000 new infections per year. And so from a data perspective, we slice and dice the epidemic by sort of key factors, risk group. And so here's some of the key risks over here on the right, which I'll talk about in a moment: sex, age, race, and region. And for all of these ways to distinguish the epidemic, we see disparities. And I want to focus really today on risk group and region and race. So here, it's a little small, I hope people can see it, but what we see here, this is just showing the distribution of HIV diagnoses in 2015. What we see here is that about 2/3, 67%, are men of sex with men. This is a group that makes up about 2 to 5% of the US population, depending how you measure it. And so that's a major disparity right there. 67% of infections are among a very minority group. And then we see other groups as well that are represented, but really nowhere near as much as men of sex with men. Intravenous drug use is really is an important risk factor, but really nowhere near nearly as present in our modern epidemic. And so this is what I'm going to focus on today. And this is not uniform everywhere in the country. There's a geographic sense to this picture. And so the colors maybe look a little washed out, but this is some work, some model-based work that we did that is part of one of our CDC grants. This is a cooperative agreement with Emory University, University of Washington, Johns Hopkins, and a number of other colleagues to do a portfolio of different model-based projects to inform public health action in 5 disease areas. A prominent one is HIV, but also STDs, tuberculosis, viral hepatitis, and school health. And as part of this work, we synthesized HIV surveillance data with a lot of different approaches for using the US Census to estimate rates of new HIV infection among men of sex with men. So the US Census, not surprisingly, does not actually ask sexual orientation or sexual behaviors. And so we really requires model-based approaches to understand how many men of sex with men live in the United States and then sort of understand rates. And the point of the major takeaway of this map is the rates of new infection are actually high everywhere in the country. So these are percent per year acquiring a new HIV diagnosis. And the areas of the deepest red color here are areas where over 1% of men annually receive an HIV diagnosis. So they think of this as sort of compounding interest. That's unacceptably high. And as you'll see in a moment, these rates of annual infection, particularly concentrated in the US Southeast, lead to what I feel is a huge public health injustice in the United States. And it looks something like this. So this is some data from a large cohort study that I got involved with as a doctoral student, and really this sort of defined the early portion of my career in Atlanta. And this was the involvement study, which was a cohort study, so a study where we enrolled large numbers of men, 803 men, and followed them for several years of follow-up to measure all sorts of infections, particularly HIV and a variety of other STIs, and try to understand what's going on. And I want to just point out this picture. This is sort of age groups. This is at enrollment into the project. And these are the percent with a positive HIV result during that project. And so what we see here is really, even by the mid 20s mid to late 20s, early in the 30s, HIV prevalence is quite high among men of sex with men in Atlanta, Georgia. So here, in our Black participants, 45–60% of men are living with HIV infection, compared to very large burden, about 15%, but lower burden among white men of sex with men. So I think there's two pieces here. All of this is unacceptable. This is 2017. We have effective therapies. We have effective prevention measures. We as a society should not tolerate this. And this gap is unacceptable. We should not have 60% of men who should be healthy in their 30s living with HIV. This project was really the first study to really show the extent of these disparities in one community. And it was really, we threw everything we had at this to try to understand the disparity. And it's a really elusive challenge that really our best answer is that there's a complex soup of social determinants, healthcare access, and sort of community structural and sexual network aspects that sort of explain this. And it's an ongoing challenge to understand what to do about this disparity. And I think this project was really a great example of how we can engage the community to both conduct the work and then also disseminate the work. We had, at the conclusion of this project, many seminars throughout the community to disseminate these results. This continued on in a current NIH-funded R01, for which I'm co-PI of, which is continuing on in Atlanta, to understand specifically among the younger Black men of sex with men what's going on. It's sort of a deep, the official sort of idea is to understand how substance use and sexual risk together sort of synergistically generate high rates of HIV and sexually transmitted infections. But I just want to highlight one important piece, is that in this period, we've had the advent of a new technology called HIV pre-exposure prophylaxis, or PrEP, which is a daily anti-HIV medication, so what's typically a therapeutic medication, being given prophylactically and daily to prevent HIV infection. This has caused a sea change in HIV prevention. We now have a medicine to prevent HIV. It's not a vaccine, but it's essentially a daily vaccine. And this is really perhaps our most promising tool to reduce the HIV disparities among men of sex with men. But it's complicated. Right? Biomedical solutions do not exist in a vacuum. There's a whole social ecology that they exist in, and there's many challenges to the implementation of this. And we've published a number of papers really understanding the continuum of issues from getting evaluated and screened all the way to actually filling your prescription and staying on PrEP daily. And this is from our element study. This is a flow chart showing that really all the ways that you can drop out from 184 men eligible to take PrEP down to 37 actually filling their prescription and taking PrEP. All men were evaluated and offered PrEP. But there's a number of ways you can drop out in terms of interest, attending that first visit, and then I don't have all the steps in here, but basically even after you attend a visit, you're evaluated. We give you a prescription. Life happens and things are complicated. You don't actually wind up taking PrEP. And so it's a complex process, and this is really where a lot of important work is going on today. And so I just want to pivot to another style of work that I'm privileged to be involved with a number of colleagues here, which is really model-based studies to translate some of these on-the-ground cohort and very fine data collections into society-based decisions, or and to help guide policies. And so with my good dear colleague in the University of Washington, Stephen Gaudreau, we had an R21 to take a lot of our cohort data and create what's called an agent-based model to really give a more fuller understanding of the HIV disparities in a simulation-based approach. And with the CDC, we've been partnering on a number of studies here that are model-based, and sort of highlighting PrEP and racial disparities. Based studies to understand what are the impacts of PrEP and other policies on the future of epidemics in the United States. So an important sort of first piece of this was looking at the rollout of PrEP according to the CDC guidelines. CDC sort of designed the guidelines but didn't actually evaluate its impact, so we sort of did it in reverse. So we sort of said if people actually listen to the CDC, what will happen to the future of the US epidemic? What will happen to other infections? So there's other sexually transmitted infections. There's been a very vocal conversation around sort of what will, as people change their behaviors because their HIV risk is decreasing, what will happen to the other sexually transmitted infections, and so forth. And we've also taken a disparities angle here. What will happen to the disparities that we see in HIV infection as access to PrEP might be different by groups? Will we actually make disparities worse by treating one group better than another? So the future of this work for me, and I think of the field, and also for me here at University of Albany, I'm taking pieces of this, but it's about bringing HIV prevention to scale. We have some tools that work, and the question is, how do we smartly and bring them to scale to reduce the overall burden of infection, but also disparities? We can't serve one community preferentially. And in fact, I think justice requires that we overachieve in groups that are suffering the most. And so there's modeling and policy-based work. A number of my colleagues back at Emory University are working on mobile health and other innovative platforms, so telemedicine-based platforms for bringing some of these technologies like scale to PrEP to reach the most men, because this is complicated and expensive. Where a lot of my focus is on improving tools for monitoring the epidemic and pinpointing persons at highest needs. We need to be efficient and smart in how we control the US HIV epidemic, and so a lot of modeling and data-based approaches are needed here. And of course, we need continued investments for both the HIV and other sexually transmitted infections. We're in this era right now where many of the other sexually transmitted infections, particularly syphilis and gonorrhea, are on the rise, and federal funds are drying up. And so this is an area I shall be in DC later today speaking about syphilis rise, and which is a very different challenge. So thank you.